My love is endless, and
A very good afternoon and a warm welcome to all the attendees of this MEPD series of lunchtime webinar. On this Wednesday afternoon, we get to nourish our minds whilst nourishing our tummies. So I hope you're all comfortably settled in, lunch at hand and all that. It gives me great pleasure today to welcome Dr. Rohaida Abdul Halim. She's our senior lecturer in pediatric dentistry at the University Technology Mara, Malaysia. She graduated from University Malaya in the year 2002. She then completed her specialist training in pediatric dentistry from the University of Otago in New Zealand in the year 2012. After which she went on to do a diploma in clinical hypnosis, that is in the year 2015, followed by cognitive behavior therapy from the London College of Clinical Hypnosis in the year 2018. Currently, Dr. Rohaida is the program coordinator for the Doctor of Pediatric Dentistry program, Center of Studies for Pediatric Dentistry and Orthodontics, Faculty of Dentistry, University Technology Mara. And her areas of special interest are behavior management, cariology, developmental anomalies, dental education, and hypnosis. So with this, without any further ado, I would like to hand over to Dr. Rohaida to start on with her talk on caries management by risk assessment in pediatric dentistry. Over to you, Dr. Rohaida.
All right. Thank you, Yogesh, for a very nice and kind introduction of me. Well, bear with me. I'm a bit reason why I'm working from home today. All right. Okay. Today, what we're going to do is just a quick recap or revisit to a subject matter that is very close to us, which is caries. Something something that we see quite often, but unfortunately, more often than not, we do take caries for granted because we thought it's our bread and butter. We've seen this every day. We are seeing it again, and there's a whole reason why. We just need to give this topic or this issue a quick revisit, hopefully with a new insight. Okay, just bear with me for a few minutes, just to share a few seconds, just to share my presentation. Okay. Caries has been the core subject both in undergraduate degrees, postgraduate degrees, and even in our daily life. But do we know what dental caries is? Do we know what are the factors that actually influence this caries to occur? And how does it occur? What are the risks that we can actually identify prior to this management of the whole thing? And eventually how to manage this? Okay, just a quick recap. This is, again, as I said earlier, is one of the most prevalent disease worldwide. We've done a lot to actually trying to reduce this. We've done a lot to identify this. We've done a lot in our daily life to cure this, or so-called trying to find cure for this disease. Because in dentistry, there's only two diseases that we have to worry about, which is caries, and the other one is periodontal disease. Unfortunately, even though it's the most prevalent disease, we still could not reduce it totally or stop it totally. We still could not prevent it from happening. And this vicious cycle just keep on going over and over again. Because we have to remember that caries actually involves a very complex process of enamel demineralization and remineralization that occurs due to action of organic acids produced by microorganism within the dental biofilm itself. Okay, so what are the factors that usually involve from dental school days or even the undergraduate students that are going, those who are revising for professional exam or who had just sat for professional exam? Everybody knows that all this while, or for caries to occur, you have to have host, which is the teeth most of the time. The patient itself, of course, is very much involved in it. Substrate, well, the main culprit for substrate can process to caries to occur, it will happen over time. So as a dentist, most often than not, we forgot about these host factors. Because when we talk about caries, the first thing that we always take for granted is, or the first thing that most of us do and are still doing, is blame the parents, blame the patient, blame everybody else, but forgot about what is actually the factor that lies behind all this process to occur or disease to occur. Okay, we are quick to judge, we are quick to say that these children that presented to us or this patient that presented to us with caries in their mouth, they must be taking a lot of sugary drinks, they must be taking a lot of sugary food. But how about the host factors? Have we taken that into consideration? For example, crowded teeth. This is because the crowded teeth usually will provide a very to stay because of the plaque accumulation in between the teeth that is crowded. This is because one of the main reason is the crowded teeth are usually difficult to clean, especially those contact areas. And this is actually in line with the first caries formation or the initial lesion of caries, which is the interproximal areas, which most of us or most of the time will go unnoticed. We'll go into that later. Okay, and how about still on the host factors? How about the frequency of consumption? For example, in young children and toddlers, the picky ones, the picky eaters, who are very choosy in eating, they only pick certain food to eat. They only like to eat at certain time. They will only eat a small amount of food, and normally when they eat small amount of food, they do get hungry quite easily. This eventually will increase the frequency of eating itself. And they breathe through their mouth, because when they breathe through their mouth, the mouth can become dry quite easily. They could change the consistency of the saliva. Saliva become more mucus-like, become stickier. And once the saliva quality is reduced or they become thicker, this actually reduces the ability of the saliva to clean or bath the tooth itself. Okay, the reason for saliva to be there is to buffer the acidity in the mouth. It is to buffer the activities of caries formation, caries progress. So once this naturally existing substance in the mouth is altered, this could actually change the whole environment, which can be more favorable for bacterial growth. And this again will set the whole chain of tooth decay itself. Okay, and how about the even in the young adults who just embark into new phase of life, where the habits or the lifestyle changes drastically. For some teenagers, they just live on soda drinks. They just live on high sugary diet like donuts, cakes, not really on the basic food which were provided by the parents, but this is something that they could get their hands on. And the currently increasing trend, the boba drinks, which is highly sugary. the sweetness level is to the max. So these are the things that can alter the whole thing, which is most of the time is host factors. Okay, then we talk about substrate. Most of us, or most of the parents, and unfortunately some of the clinicians out there forget to actually address the issue of flavored drinks, flavored milk for children. Because rather than not having anything, they would rather have the child drinking chocolate milk than have nothing, which is something that we as a clinician have to change. We have to reset. We have to ask them to unlearn and relearn the whole thing, because not necessarily by giving something that is sugar, dairy in base or dairy product, but with increased sugar can help in the whole thing. You have to change this whole mindset. You have to address this from the grassroots. Okay, Hannah, how about the yogurt drink that is highly sugared, such as Vitagen? I'm not saying that this is bad or good or promoting, but this is one of the other things that we have to consider. Milo, which is considered as health drinks. When all of us as a clinician know that this is detrimental to health and also the oral health specifically. But are the parents out there know? Are the teachers aware that these drinks are high in sugar? Are the caregivers, child carers know about these drinks? They are not healthy. And on top of that, how about the food, the snacks that they provide, they give to these children, such as cookies, biscuits? And these are the things that we have to actually address from the grassroots, addressing and educating them that this is actually the main culprit for caries to occur, on top of the existing host factors and also the bacteria that is already in the mouth. This is something that we have to deal with. We have to just live with the bacteria. Okay? So the whole thing over time will or can actually result in caries formation. Okay? Sorry, bear with me. I seem to be speaking faster than my slides. Okay, so this is to detect these carious lesions. And how do we do it? First and foremost is just using our eyes, which is visual, or we can use any codes that is available in the, and tactile. It can also be done through tactile inspection, which is using blunt probe. And these alone are not enough. It have to be coupled with, or have to be aided by the radiography examination, such as bite wings. If the child could not tolerate intraoral radiograph, maybe we can actually consider extraoral radiograph. Because for caries to occur, we have to make sure that all the factors are there. If the risk factors are removed or altered, inshallah, this process can be stopped or reversed. Okay. Once caries is detected, as I said earlier, it can be stopped, reversed, and even prevented, because is involved in the caries formation itself. For example, when you're doing the risk assessment, you have to actually check what are the factors involved, whether it is just diet, whether it is also the host factor, whether it is the saliva, which is a protective factor. It's supposed to be the protective factors. When asking all these questions, you go systematically. There's a lot of caries risk assessment forms out there that can be used, and there's no one form that or one tool that is superior than the other, or one is lesser than the other. What we can do is we can adopt and adapt accordingly. So whichever that you are comfortable in, you got comfortable working with, those are the things that you have to know and use. The most important thing that you have to identify is actually what are the factors involved first? Whether the child is having enough flow of diet involved in inducing the caries. For example, whether the child is actually having a lot of sugary intake, such as flavored drinks, flavored milk, flavored biscuits, anything that is sugar enhanced, because sugar are addictive, and once we have this in our embedded in our, we have this craving for sugar or sweet things every other day. So, and another thing that you can consider, the moment the child actually opens the mouth, is actually oral hygiene. You can quickly assess whether the child has very poor oral hygiene or very good oral hygiene, and from there you can move on to whether the child is actually receiving adequate or effective brushing, because there's no right and wrong brushing technique, or one technique superior than the other. Parents are doing at home is actually effective in removing the plaque, because that's where the bacteria is usually. Okay, so we're going to, and again, when I talk about the risk, we have to take into consideration the protective factors of the risk assessment itself. Does the child receive um, maximum dose of fluoride that is beneficial from the toothpaste itself? In another word, you can actually ask or find out whether the child is using, the parent, the family is actually using fluoridated toothpaste. If they are, what is the amount of fluoride? Are they aware that there is a different amount of fluoride in the children's toothpaste? Even between children's toothpaste, the amount of fluoride differs. How about the adult toothpaste? All adult toothpaste contain fluoride. So these are our job. We have to actually find out and make sure that our patients and the family are aware that there are different amount, if they are not receiving enough fluoride from the topical toothpaste, from the toothpaste, are they living in fluoridated area? Mm, In another word, whether they are receiving fluoridated water, or are they using well water, or even though they live in fluoridated area, but they are not using the tap water which contains fluoride. Those are the things about fluoride exposure. Next, we can move into how about the quality of the saliva. Is it thick? Is it flowy? Is it enough? Is it sufficient? Those are the things you have to check, because these are the protective factors that can actually counter the risk. How about the medical history? Whether the child have any medical problems that actually have some effect on the saliva production, whether there is any medical situation or medical problem that actually impedes the oral hygiene care itself for the child. Those are the factors that one another important area that we have to look into is the child's and also the family recent caries activity, whether there is any caries in the past 12 months, whether the parents itself just had any restoration. The way to ask is actually not, do you know you have caries in the mouth? No, it's not like that. Have you had any restoration? Have you had any dental visit in the recent month, recent year? If they say yes, what was the visit for? That's how we can actually gather the information. Because not everybody know why they are at the dentist, or what does the dentist do to them. So we have to find ways of getting this individual information. And last but not least is the presence of lesions, be it white lesions, cavitated lesions, because these are the clinical indicator which can actually bring us back to the question, what actually causes these lesions to be present in the mouth. Okay. Oh yeah, things that can lead to, maybe if there's some defects, for example, there's hypoplasia of the enamel, maybe that area can become plaque retentive area. If there is hypomineralization of the enamel, which causes the enamel to become very brittle and soft and breaks easily, that is another area for plaque accumulation. On top of that, that the child can actually present with other behavioral issue because the child has been undergoing a lot of other issues too. So these are the things that we have to consider and actually address when we are gathering the information about the caries itself or caries risk. Okay, once all these informations are gathered, we can actually categorize the risk for the patient, again, based on the factors involved. For example, if the child doesn't have any factors that increases the risk for caries, for example, the child is actually is brushing twice daily. In a young child, the parents actually assisted. In a slightly older child, they brushes by themselves but supervise their parents, uses fluoride. We can categorize them in the low risk category group. And the next one, if any of these factors are present, for example, the child does have caries lesion in the mouth and then is not getting full amount of fluoride or is not getting the optimum fluoride exposure, this actually contribute to the risk to become a bit higher. And the worst group is actually the very high caries risk group, when they actually tick almost every single boxes in the caries risk assessment form. Because there's no such thing as someone in between or middle or medium risk, because we have to take it, just have to think about it. If the person is actually in the middle, if we do not do anything, what will happen to the child? Is it going to move to the higher recommended by Featherstone? Is actually to categorize them is either in low caries risk group or high caries risk group and very high caries risk group. This is just to make it easier for us to actually channel or optimize the management of the caries itself for this individual group of patients. Okay, again, to achieve just the reversal of the process of the caries process and to prevent future caries from happening, or at least to slow down the caries process itself by altering one or more of these factors. Okay, and so having said that, we have to know about the risk management, we have to identify these caries. The other thing that we have to take into consideration is actually to empower our auxiliary staff, such as our dental nurses. We can even approach the dental nurses in the KKIA or any areas that you are working at. We can actually empower our dental officers, our fresh graduates, so that we can, so that these people, they can help in disseminating the information about dental health education. Because caries alone, caries management is not just the responsibility of the pediatric dentist alone or the dentist alone. It's actually a group effort. It have to be a commitment or teamwork, or from parents, from patient itself, from auxiliary staff and ourselves, in order to achieve optimum or successful outcome of it. Okay, so once the dental clinician identified all these factors, we can actually prevention, or we can actually make it more intensive, and we can channel it towards something that is closer to counseling, which can actually be provided by our non-dentist practitioner. Because to be honest, these non-dentist practitioners are also key partners in caries prevention, because they are the ones who actually will be the first person the child sees or the family sees. So by empowering them with this knowledge, giving them the right tools, how to actually check for the predictive factors or the caries factors, we can we can train them to become the motivators. We can train them to become the person who actually counsel the parents, teach or educate the parent how to actually manage or or the medical nurses. They are the one who can actually do a simple thing such as lift the lip of the child at every child's visit, just to make sure that the child is actually not having any lesions or not having any increased risk for caries. Um, Increased risk for caries. So they are the first person that we can actually educate and empower, just to make sure that this whole thing can be a success. And our dental nurses, we can teach them how to actually identify which patient are at low risk or high risk or very high risk. So they themselves can actually intervene early. They can actually plan for something that is more intensive or tailored to the child's need, because they will be the one who could actually apply topical fluoride for the child. And even the for patients, parents, which when you take all this into consideration, these are the aims. We are aiming to address the risk factors before the caries actually manifest. Okay, so for the prevention or preventive protocol, this is we're talking about the lesions that is not cavitated first. Okay, what we can do, we can come up with preventive plans. If you notice a little bit of plaque or how to address the plaque issue, what we can do is we can reinforce the oral hygiene or improve the efficacy of brushing itself. And then if we notice the diet is already good, what we have to do again, because they are also human beings, we have to reinforce the good dietary habit in this family. And again, for fluoride, check whether it is being used appropriately, whether it is enough or adequate. And fissure sealants, this is fissures we have to seal. All other factors, other important factors that you have to take into consideration too, such as the child itself, whether the child is cooperative, whether the child is of age that can understand instruction, can allow you to actually isolate the tooth properly to get moisture-free environment for the success of fissure sealants. And the tooth itself, you have to assess whether the tooth is fully erupted or whether the tooth is partially erupted. Can you seal the tooth? Even yes, the tooth may present with a very deep fissure, but if it is partially erupted, you are not able to actually isolate it very well, the fluid from the clavicular crevice will just continue to flow into the area, your working area, and this can actually lead to failure of the fissure sealant itself, which defeats the purpose of the whole fissure sealant placement. And for this low risk or 6 month period, okay? And the next group, let's move to the high caries group. So now when you move, when we talk about the high caries risk group, we have to think about how to decrease the risk in this patient and how to heal the existing early lesions and to prevent new lesions from occurring. Same thing, plaque. If the child is old enough, we can disclose the plaque, show it to the patient or the child, and ask the child and the parents to actually remove um, the color and clean appropriately. And diet, yes, you have to advise against, it's not just the sugary intake have to be reduced, you have to also advise against the frequent fermentable carbohydrate intake. Fluoride, same thing, check whether it is being used appropriately, whether the child is actually using fluoridated toothpaste, whether the child is brushing effectively, whether up, you have to think about or consider about professional application of fluoride such as varnish if the child is below 6, and whether the child will benefit or not from fluoride gel. Okay, facial sealants, again, the same thing. Um, Apart from sealing the molars, you have to take the child status and the tooth status itself into consideration before deciding or embarking on sealing all the sealants, all the fishes. Okay, recall 6 monthly, because this is when or where the lesions can recur if you miss. Okay, or if the high risk factors remains or not altered. And the other group, the last, the most at risk for caries group is we have to think about how to heal and restore or restore this existing lesion, and again how to prevent it. Same with the previous group. You actually analyze the child's diet or the person's diet, or maybe the whole family's diet if needed. And a very simple way of doing it is by giving or doing the diet diary, which once the diet diary is submitted to you or written to you, you can actually analyze it and identify what are the most frequently consumed food and advise against that or alter a little bit. Okay, fluoride, same thing. They check whether it is appropriate use, enough concentration of fluorides, fissure sealants, or restoration is actually to restore all the open lesions. Then whether there is a need or not to apply sealant to all molars and premolars. Okay, recall for this group of patients is 3 monthly, and subsequent recall can actually be spaced out to 6 monthly if there is no there's no active caries, but these have to be aided by the radiographic investigation. Okay. We have to really understand what fluoride is. These are the areas that most of us forget or take for granted too. In a nutshell, or from what Cochrane says, from the Cochrane review, fluoride can actually be divided into systemic and topical. So what are systemic fluoride? You can actually get it from the naturally occurring fluoride, whether in water or soil, or from the water fluoridation from the national program. And the easiest is actually the topical fluoride, which can be either professionally applied, either through varnish or gel. Both have a different and its own advantages. Topical fluoride for home use, which is something that we really have to empower our children and their families. We have to make sure that they are using, or we have to actually educate them that they need fluoride. We're going to talk about the content and amount of fluoride for each age group later. And for fluoride in the toothpaste to be beneficial for the child or to reduce the caries incidence, it have to be between 1,000 to 1,450 parts per million, and it can be with or without the arginine and calcium. And another extra tool that can be used at home is actually fluoridated mouthwash, which most of them contain about 900 parts per million of fluoride. So in summary, what we can say about fluoride is a lot of research has shown that just from the fluoride toothpaste itself, there's a reduction in the caries incidence. So we can actually top that with fluoride varnish or gel. But when we talk about the fluoride mouth rinses, we have to be careful in advising evidence showing that it is beneficial for the primary dentition or deciduous teeth, but it has been shown to reduce about 26% of caries incidence in the permanent dentition. Okay. And the other thing that we have to really, really remember and revisit is make sure that we understand what are the principles of effective use of fluoride in the toothpaste itself. Number one, first and foremost, is effective brushing. The key word here is effective. So whichever technique that you decide to teach or empower the patient to use, does not really matter as long as the brushing is effective. The amount of toothpaste, it have to be age appropriate, and it doesn't have to be a lot. For example, just like the one that they've always shown in the TV ads, almost the whole length of toothbrush is covered with toothpaste. That is most important thing is the amount of fluoride in the toothpaste have to be at a maximum concentration. This is in relation to the risk, whether it is 1,000 or 1,450. The other thing that we have to keep on emphasizing is actually no vigorous rinsing after brushing, because when you brush with a fluoridated toothpaste and you rinse afterwards, you could actually create the washout effects. In a simple word, you are doing it for no reason, for no purpose. Because you brush with a toothpaste, fluoridated toothpaste, you rinse, there's nothing left. Okay, so what you can do if patients say, oh, or the parent said, I'm worried that the child will swallow the toothpaste. Don't worry, ma'am. Don't worry, puan. Jangan risau, puan. What you have to do is just remove the foam on the tongue, whatever that is there that the child can spit out. Ask the child to spit out. If the child could not spit out, just get a handkerchief and wipe it off. But the inshallah, the child would not swallow it, because when the toothpaste is dry, there's no water involved, it is usually is sticky. Okay, so you won't actually swallow it. So there is no issue about using too much fluoride in the toothpaste um, can cause harm or can actually induce harm to the child. Because we have to know what is effective and what is appropriate to be done. And of course, we have to keep on reminding them not to swallow the toothpaste. What I can share from my experience is actually the best way to discourage swallowing is actually not to buy or not to actually advise them to use flavored toothpaste. Because when a child tastes something that is nice, smells as something that is nice, automatically the child have the tendency to actually lick it, swallow it, and eventually wants more of it. So what we can do, we can train them from the beginning, from as young as 1 year. Whatever taste that they or whatever likings that they have at the age of 3 or 2 or 4 is actually from conditioning, because they are so conditioned to the taste. They are so conditioned to the saying, or the parents saying, okay, this toothpaste is not for you because this toothpaste is too hot, too pedas, too spicy. So we have to change that mindset. We can start training them, and inshallah, if we start doing it, we share our experience with our own children, they will eventually will be interested to actually try it. And the other thing that we have to emphasize for these parents is to supervise the children's brushing. For those who are 2 years and above, or 3 years, once they know how to do it themselves, or in a younger children or toddlers, the parents itself have to actually brush for them. And the best time to brush is actually after ingestion of food. And again, emphasize on the keeping the toothpaste away from the go to them how much is a smear, how much is pea size. For any children below 6, it doesn't matter what is the size of toothpaste, because amount of toothpaste does not actually matter. It will not affect the efficacy of caries preventive caries prevention. Okay, so we've come to the last slide actually. Just a summary of all that we've talked in a very short time. Caries management itself is actually a lifelong process. So once the person had the exposure to the caries, what we call it, the exposure to the factor that increase the caries risk or caries incidence, that's when the primary prevention should start. This is just to maintain the physiological equilibrium, so that the condition or the environment of the mouth is not actually of the caries. And this is what we call the preclinical phase. Okay, but once the parents or the carer have managed to notice there's something not right with the two, there's white spots, there's yellow spots, that's when they should come into realization. This is when the early intervention or secondary prevention should start, which is at the clinical phase. That is our job, because this is the reason why we have to emphasize on getting regular dental checkup, because without regular dental checkup, a lot of these early lesions, early disease initiation can be missed easily. Okay, once this all taken care into, inshallah, the caries process itself can be stopped. The process itself can be reversed, and new lesions can be prevented from happening or occurring. Okay, because once the parents or the patient come to you with open cavity, that is considered as a late diagnosis, and then restoration, and then followed by more restoration if the feeling restoration failed, or if the child is the family is not following the preventive protocol that you've planned for them, the new caries lesion occurs. The whole thing, the whole process will just keep on going over and over again. Okay, and sometimes this can be very late. It's too late for the child and the family. All right. Okay, I think that's all. And before I end, just a small reminder that there will be another series. The next webinar will be on management of dental trauma by Associate Professor Dr. Shani Anmani from University Malaya. She'll be speaking on that topic on the 23rd of Wednesday. So please book your diary, reserve a seat, and join us in the next session. With that, thank you.
Thank you very much, Dr. Haida, for a very interesting talk, and especially for sharing your experience with us today. Um, we have just a reminder to all the attendees, we have the link for the certificate right in our chat box. So kindly refer to that to put in your to put in your names for the CPD points. Yeah. So the link is up already, and you can start filling that in. So the questions are coming in for Dr. Haida. And
Okay.
so here
Yeah,
we
I
go.
think we have a few minutes. Oh.
We have ample time. Lots of questions you can answer. We have 15 to 20 minutes. Um,
Mm-hmm.
so the first question here we have is, at what age a child can start using the chlorhexidine mouthwash?
Okay. Thank you for the question. To be honest, for a child to start using chlorhexidine mouthwash, they need to fall into the very high high risk category, very high risk category. This is because number one, any children that could not actually gargle or spit out properly definitely are not advised to use any form of mouthwash. Number two, this is the nature of the chlorhexidine itself. It can be it is something that is not nice for the child to use. They can actually cause stains, but in a very high risk group, you can actually plan for chlorhexidine mouthwash to be used for 7 days in a month, and then you stop for 3 weeks. You repeat in the next month as the 7 days. It can be like that. This is just an adjunct to whatever that you are already using for brushing, which is what is the first thing that you have to emphasize. But the effective brushing, the maximum amount of fluoride in the toothpaste itself. That's the first thing that you have to emphasize. Okay.
Okay, thank you, Dr. Haida. Now we carry on with the next question. Someone here is Nadiatul Akmal. Yes, she's asking, which comes first? Is it flossing or brushing?
Okay, thank you, Nadia too. Again, it comes with age. It comes with a child manual dexterity, which is very important. What is important first and foremost is to, again, to get the brushing correct first. If the brushing is effective, is enough, inshallah flossing is not really needed unless the child have a very crowded dentition. The parents can actually help with flossing. Then you can start introducing flossing to the child. So first and foremost, I always say go for brushing, effective brushing first.
Yes, effective brushing is the most important thing, isn't it? Now the next question here is, at what age is it advisable for children to stop using a pacifier or bottle feeding? I think this is something that is a very, very interesting question.
Oh,
Because
okay.
yes, we face this bottle feeding to the age of 5, 6, 7, isn't it? So what's the advice for patients, the ideal age to stop bottle feeding and pacifier use?
Ideal age to stop using pacifier and feeding. Okay, thank you, Azim, for the question. I can see the question. Um, hmm. To be honest, Malaysians being Malaysians, we tend to sayang our children a bit longer. Ideally, the moment the child can hold a cup or can drink from sippy cup, you can actually stop bottle feeding. You have to stop, especially with the night feeds. Once in a while, maybe boleh lah kot, can still use, but pacifier, if you have to use pacifier to actually replace something, it can think pacifier is also an adjunct, so it can be stopped the moment the child can understand instruction, maybe at the age of 1, but to slowly stop using it. But it's not easy. Being a parent myself, it's not easy. I fully understand that with us being the working parents or even stay-at-home mothers with a lot of children and other commitments, so it's not something that is easy to deal with. So what you can do is slowly to reduce the frequency, slowly for the pacifier, slowly you can advise the parents to slowly make it not that easily accessible to the child. Campak jauh-jauh ke, throw it in somewhere far, somewhere they can see but they cannot reach. That's actually again will have to be coincide with, will have to be at the age of the child that can understand the instruction, can understand the reason why they need to stop. There's no point of trying to stop but you are having a very stressful moment. You can go bonkers doing ID.
Okay. I have a question of my own actually, Dr. Haida.
Oh gosh, oh gosh.
Oh no, not about
Eh?
it. It's something. Well, I completely agree and see the benefit and the necessity of caries risk assessment in managing dental caries. Not only in children, I think in any patient for that
In any
matter.
patient, yes.
In any patient for that matter, I think it's the cornerstone and the pillar of managing dental decay. But my question is this: you see, in a busy practice, when even especially in the government service, where you have patients coming in and out, you have got such a busy time with the sheer volume of the patients, and admittedly, taking a history to assess caries risk is time consuming. So I would just like to ask if you could share your experience and if you've got any tips or tricks on how we can, as dentists, glean out a very quick, in a quick and efficient manner, glean out the necessary points for assessing caries risk uh, in our patients.
Okay, thank you, you guys. This is something that I've actually just shared, just recently discussed with my postgraduates or our clinical residents. Yes, in our very busy practice, especially in the government sector, or even in private sectors, it can be busy at times. And sometimes we tend to overlook this matter. What we can do is, this is when you have to put on your makcik bawang hats. Okay, be very nosy, look into their water bottles, look into what they carry to the clinic, because most of this family, they will have some tidbits with them, they will have some form of reward waiting for the child. So this is one of the way to actually have a quick and general overview first. Then slowly you incorporate the question. The moment the that's when you can actually start slowly ask the question while at the same time you are doing your quick assessment. And this is when your assistant, the nurses in the clinic, can play their role. While you were talking, they can become the makcik bawang too, the joyah of the clinic, listen to the conversation, pick up the important points, and summarize from there, so that these informations can be utilized in the next visit. Probably if you don't have time in that first visit itself, because sometimes they will present to you with abscess, pain. You have to address that one first. But we I still have to emphasize that we still have to ask a little bit about their diet. This is where you have to get the nurses, everybody that is present in the clinic, to pasang telinga a little bit lah. Jadi kepoh sikit.
Isn't it? It's using your ears, your eyes, and even
Every
your nose to sniff out to sniff out the caries risk. Because I mean, oftentimes we do find patients walking in with something in their hand, with a box of carbonated drink or something like that in their hand. So this happens very often. Um, uh, so I think as far as the yes, we've gone. Some more questions have come in.
Oh, okay.
Here we go. At what age can we start children on fluoride varnish treatment?
At what age? To be honest, fluoride varnish treatment is advised to be used in children below than 6 years old, meaning whenever they presented, number one is the clinical factors, which is a predating factor, early caries lesions or even cavitated lesions, and they fall into high caries risk group. Yes, we can start applying fluoride varnish on them. It can be as young as 1 year old if they presented with all these risk group. Because with fluoride varnish, you can control where does it flow to, where does it go to, and you can actually just target the area of the lesion. It doesn't flow anywhere else. It's different from fluoride gel. Fluoride gel, yes, you have to use in older children. I would say older than 6, or the moment the child can actually spit out or can control whatever that is put in their mouth, you can start using fluoride gel. But younger than that, definitely fluoride varnish.
Okay,
Hope
thank
that
you.
helps. Mm-mm.
Yeah, thank you. It's basically the caries risk assessment, isn't it?
Yeah,
When the
it
risk is
goes
there,
back to the risk
when
assessment.
it goes back to so everything, all our treatment plan actually ends up going back to the risk assessment. So that's how important the risk assessment. There's another question here regarding the age to introduce toothpaste for during brushing.
Ah, as young as the first tooth comes, the age for introducing toothpaste, but amount of toothpaste differs. Okay, below 1 year old or only one single tooth, maybe you can actually go away without using any toothpaste. But I wouldn't recommend that straight away. Again, go back to the risk assessment. But as young as 1 year old, you can start introducing the fluoridated toothpaste. Here, what I'm meaning is actually at least 1,000 parts per million of fluoride toothpaste. Amount of toothpaste that matters. You have to use just a smear of toothpaste. You have to make sure the mouth is actually dry, meaning no gargling with water prior to brushing, no wetting the toothbrush before. If you want to clean the toothbrush before using, you can clean it, wash it, but dab it dry. Then only apply the toothpaste, start brushing. Parents, what is important, parents have to have the handkerchief or tissue ready in their hands to wipe off whatever excessive toothpaste or excess toothpaste that is present in the mouth. This
Okay, we have another question here. Cassandra's asking if you could please share the slide on the age-appropriate fluoride toothpaste, which I think you just mentioned in answering the previous question. And if there are any toothpaste in the market available which contains higher fluoride than the normal 1,000 part per million.
To be honest, the one that we are using on daily basis, which is I think everybody can relate to, is Colgate. Colgate contain 1,450 parts per million of fluoride, and some of the children's toothpaste now also have at least 1,000 parts per million of fluoride. The one that I've just checked recently is Jordan for children. The Colgate, the one that they are giving for free, is also higher in price. So we are actually on the right track as far as I know. Appropriate toothpaste. The problem comes when they get the toothpaste outside of the normal market, such as the organic toothpaste from a certain company, or they actually import the toothpaste from Australia or New Zealand, because these areas, they have other issues such as, sometimes, not all, they have issues with their water fluoridation. They have a high fluoride content in their soil itself. So definitely the fluoride amount is different from what is available in Malaysian market. This the other thing that we have to educate our patients, because our patients can get the toothpaste from everywhere, all over the world, because it's very easy to get them now. So these are the things that we have to empower them. They have to know what to look for, where to look for those information. Unfortunately, some toothpaste, they do not write the content of fluoride on the box itself. You have to purchase them. It's only inside you can see the how much of toothpaste is, how much of fluoride is actually in the fluoride. In fluoride, so of no use. It's as good as using just dishwasher or body wash.
Oh dear. Okay, now I mean I've I've pretty much read the questions that have come in the chat box, but I have another question of my own again to add.
Oh, yeah. We should not be asking.
I'm keeping it going. Talking on the topic of fluoride, you mentioned about these proprietary brands and special brands which come from overseas, organic toothpaste. We do have a lot of health conscious parents. Sometimes parents, rightly or not rightly, we don't know. I mean, we can't say. But who have reservations about fluoride use. We as dentists, we are convinced on the benefits of fluoride. But how do we convince, or what kind of advice, how can we structure our advice to parents who are absolutely convinced that fluoride is actually detrimental to their child's health?
Okay, that's a very, very valid question. Very good question. These are the kind of parents that I usually get in the private practice, unfortunately. Uh, all that I can do is actually share how I deal with these kind of parents. These knowledgeable parents with unfortunately half-baked knowledge. But we cannot actually condemn them straight away, because they are doing for what they think is the best for the child. What I do, or what I can share, is actually how I deal with these parents. I usually get them to bring the toothpaste to me so that I can actually look into the content itself and make an effort, actually go to the extent, explain what are the contents about, each and every one, every single content. And of course, because I already asked them to bring, I also did some homework beforehand, prepare myself what are the evidence about fluoride. So I bring it to them, present it to them in the next visit. So this is also available in your dishwasher, in your sabun basuh. So these are similar things. And it's also present in the so-called organic toothpaste, for example. So that's the first point. When they see that, most of my patients, Alhamdulillah, fortunately, ataupun dia orang sebenarnya percaya I bulat-bulat pun I tak tahu, they actually believe, okay, they stop at that. Fortunate for me. But some they actually go further than that. They will bring some evidence from anti-fluoride. They say, okay, this is actually causing some brain damage. The famous thing among Muslims, this is actually something that is not halal. It comes from animal bones. What you can do is you can sort of tie it with whatever that they have in the house. For example, as simple as the plates, the expensive plates that they have. If they have china, is it bone china? So bone china, how much does it cost? So if fluoride is supposed to come from bone, animal bones, you can imagine how much it will be. Encountering in their daily life. Because sometimes it's not easy. All these people, they are very good in actually debating. We, as a dentist, not that good. Yes, we work closely with the mouth, but unfortunately, we are not good in explaining why, or we sometimes cannot rebut the argument. That's our weakness, or at least my weakness.
Yes, yes. We do have to hone our skills in convincing the patients and parents on fluoride
Mm,
use sometimes. I mean, we are convinced, but that. But thank you for your
mm,
tips on managing or how to advise parents who are reluctant to use fluoride. Um, I think for now we have covered all the questions, and we've had a very, very productive, fruitful, and informative lunch hour talk. Thank you, Dr. Rohaida, for gracing us with your presence and your wonderful talk, as well as sharing all your experiences with us. So, with this, we will end our uh, lunch hour series for today. And I would like to remind all the attendees again that the link for attendance and CPD points is shared again towards the end of our chat at the chat box. So please fill up the form and till we meet again on our next talk. Thank you, Dr. Rohaida.
Okay,
And
thank you again, your guest. Thank you all for your attention, for your time being with me. All the best. Have a nice day.
all right, have a nice day. Thank you, everyone.